Okay, guys, so hospice and palliative care. And so I did work as a hospice nurse for a while, and so I have experience with it. It's hard. For me, I loved hospice, and the reason I stopped is because I was taking care of my mom and she passed away and I didn't want to go back to doing it. But it's an amazing experience if you have the heart for it, because you're really supporting someone who is leaving this earth, and in a way that is hopefully peaceful, because you're there to help them and to hold their hand. And we'll talk about some of what clients need as they're transitioning, and what we offer them. First, I want to talk about, there's 3 definitions. So curative care. Curative care focuses on curing disease. You have diabetes, you go to the doctor. You have COPD, you go to the doctor. You know, you have whatever disease you have, you go to the doctor, you're medicated, you're changing your regime, you're dieting, you're exercising, you're doing whatever you need to do to feel healthy. At that point, you can have palliative care come in. And palliative care is symptom management. But you're still seeking curative care, okay? You just need a little help with whatever the symptoms are that you're having. And once you get to the point where everything you've tried isn't working, you say, okay, I'm good with this, and you're going to transition to hospice. And hospice is really, it's the focus on improving the quality of life for patients who are dying, okay? So it's not curative, it's symptom management, but essentially you want to keep people who are facing death comfortable as we can and as supported as we can. So palliative care, again, it focuses on relieving pain and providing comfort. It's pain management, it's emotional support, it's treatment for anxiety, okay? And it tends to be the same staff that provides the hospice care. In hospital, it may be a separate team, but the community hospice tends to be also palliative care. They tend to offer that as well. And the other thing about palliative care is that it's paid for by the client's insurance. Okay, so, pardon?
What did you say?
It's paid for by the client's insurance. Okay, so insurance will pay for it, but it's based on the coverage that they have. And I know, like with some of the palliative care, people, when I've called them and said, I think that you should come in and help with this person, they'll ask me for their insurance information so they can run it before they come. And that's just our system in the United States. But it's someone who's still living with a chronic disease. They're continuing to undergo treatment, but they're nearing death, usually. Hospice care. Hospice care focuses on comfort, pain, and dignity, okay? It includes palliative care because we're dealing with comfort care. But it also, as we said, it focuses on improving the life of a patient who's dying and also supporting the family members. Because we know that when someone is dying, the whole family comes, and the whole process is a process for everybody. It's not just for that one individual. And we'll go into a little bit more detail about that later. For hospice, you need a doctor's order. So their primary doctor will write an order saying that the client has 6 months to live, and they've declined any further treatment. And then hospice can come in, the team will come in and evaluate the client. And as long as the client fits the criteria for end-stage care, then they can sign them on. And essentially, it's just that there's nothing else that we can offer these clients, and the benefit of continuing treatment may outweigh, the burden that they're going to feel because of it. Okay, because they're at a point where they're tired, they're exhausted, there's nothing else they can do. It is homebound care, so it can be in a facility, and a lot of times people will go to those facilities to give the family respite, but a lot of times hospice is at home with the clients in their own home. And the other thing about it, once someone is signed on to hospice, Medicare takes over all payment. And Medicare dictates what can and can't be done, what the criteria is for remaining on hospice. Every 6 months, these clients have to be reevaluated, and they have to continue to fall under the category of Medicare's criteria. We had a client once when I was working over at Vinny Hospice who she fit the criteria, and then we were with her and we were providing all this support for her, and she got better. You know, she still had a terminal illness, but she got to the point where she could function more, and we had to kick her off And the family said, well, I guess it's a blessing. They can always come back. So it happens that sometimes. Sometimes it's just that people need a little extra support, and they find, they get a little better. But it doesn't mean they're not going to come back. It just means that for the time being, she was doing better, and we could not offer the service anymore because Medicare wouldn't authorize it. Okay, I just want to do these 3 definitions also because there is a difference. I mean, we sort of use this whole concept of spirituality, religion, and faith interchangeably, but it's different. Spirituality helps a person deal with the unknown elements of life that gives them purpose. And each person's spirituality is unique, okay? So whatever brings you joy in life, I mean, I can sit on my back porch and watch my birds and just, I'm in a moment, right, where I'm feeling at one with everything. So spirituality is less defined. Religion is organized. It's an organized collection of beliefs, cultural systems, and worldviews that relate to humanity and to an order of existence. Okay, it's just the basic definition of religion. And then faith is confidence or trust in a person, a thing, a deity, or any doctrine or teachings of religion or view. So they're subtle differences, but those are the 3 differences, the 3 definitions. So when we talk about the emotional experience of dying, okay, or of nearing death, there's always a wide range of emotions. I mean, think about it. There could be sadness, there could be fear, there could be anxiety, there could be anger, right? Hope. There are no rules, okay? Everyone's emotional reaction is their own personal reaction based on their own personal experiences. So each person is unique and reacts differently. How the client expresses their feelings can depend on a couple of things. First of all, the personality. If someone who is really withdrawn, maybe, and stoic and quiet, they may be more accepting, they may be processing it differently than someone who it might be more outgoing and outspoken. They might be more angry in how they respond to it. So their personality is going to affect how their emotions are being expressed. Their life experience, someone who's at the end of life. Our clients who are older, they're in their 90s, as opposed to someone who is 35, right, who passes. And I had a brother who died of leukemia. He was 34 years old. It was a very different experience taking care of him than taking care of one of our clients who were older. And then faith. If they have faith and they really feel it strongly internally, it provides support and it provides comfort that maybe someone who doesn't have faith doesn't have. And then the spiritual experience too. We want to respect the client's spiritual beliefs and wishes. And we want to remember that, again, these are all personal and unique to an individual. And when we face death, some people become more spiritual, they believe more. Some people call their belief into question. It's like, why me? Why is this happening to me? So we want to be supportive and non-judgmental with our clients, regardless of how they're reacting. We don't want to impose our belief systems or our needs on our clients when we're dealing with them. It can be sad. There might be a time where they feel like the family gets together and they're celebrating their life. And so it might be a time of bittersweet joy, And it is just a time for the families to get together. And we're going to talk about the families a little later too, because sometimes that becomes more challenging when the families are together based on their history. But some questions that might arise, they might say like, what did my life mean at this point? What was my purpose? And did I fulfill that purpose? Where do I go when I die? Some people have faith that they think they know where they're going. Some people may question that at that point. Will the family be okay? Will my kids be okay when I'm gone? These are all other questions. And then if they have unfinished business, that might be an issue too. So they might need to clean up some things before they go. And then spiritual distress. As I said, we all have different spiritual beliefs, but there might be a period where the diagnosis and the illness and the suffering start to conflict with their value system. And lack of support may be availability of their practice, but when someone starts to question their belief system, their faith, and their hope, that would be considered a spiritual distress type of a situation. There might be a need for involvement and companionship. There might be a need to, as we said earlier, resolve unfinished business, and that might be affecting them. There might be, they might just need to even just prepare for death, to resolve any distress, any conflicts they have in their families, any saying I'm sorry to any people that they've hurt and they feel they need to make those apologies to. If we want to support our clients, we want to go with them to where they are in their place and time. Maybe even we can sit and read spiritual texts with them, and that might be supportive. Even taking them for walks outside, allowing them to be in nature might be helpful, especially if they're not bedbound yet. Playing music, listening to their expressions and listening to what they're saying. And now again, never imposing our values on them. And it's hard for us, especially if we have a very strong sense of who we are as far as our religion and our faith goes. But some people maybe don't even believe in it. We want to respect the fact that maybe someone doesn't have a religious belief, and we don't want to impose it on them just because we do. Any questions so far, guys? No? Okay. Cultural considerations. So all of these things, you're going to have emotional considerations, you're going to have spiritual considerations, and you have cultural considerations. And we gave you a really beautiful handout on that. One of your handouts talks about the different cultures, the different backgrounds, and then their beliefs. Because it's important for us to understand the end-of-life cultural traditions and rituals of our clients. But we want to respect their beliefs and customs. We want to understand that the experiences that they had growing up, the education that they had in their family, the opinions that their family had, all of that affects how they're feeling at this point in their lives. And a cultural consideration, we want to make sure that what feels right for the client is what we're supporting when we're working with them. Okay. So it's just important to remember before we go on that all of the experiences that we have when we're nearing death, they become very personal. It becomes very important for the client to work through whatever they need to work through in order to comfortably let go and pass and leave this earth in a way that's supported and comfort and fearless, okay, fearless. So the hospice team, you all are part of that hospice team. You have a physician, you have a medical director that runs the hospice program. The client's personal physician may or may not be involved once the medical director takes over, but ultimately the medical director is going to take over and manage the pain and the symptoms of the client. We've got nurses that are going to be there. They're going to be coordinating care. They're going to educate the family members on techniques to help keep the clients comfortable. They're going to be there for you guys if you have questions as you're watching for the changes in the client, and maybe they need to come, and reevaluate the client and maybe change medications up and stuff like that. There are STNAs that usually work with hospice. They'll come out once or twice a week to help with bathing and personal care. There is a social worker who is there to provide information and coordinate community services. But other things a social worker may do would be something like a living will or a power of attorney if they don't have that yet. And also hospice and the social worker will make funeral arrangements. They'll take that responsibility away from the family. They'll ask the family where they want to go, and then they'll go ahead and make all the arrangements and have the funeral home on call for when they need it. Chaplain service for spiritual care. It's usually non-dominational. I know at Vinny Hospice we always had Rabbi Akiva, but we had another chaplain who worked with all of our clients too, and she was pretty amazing. Anyone who works in hospice is really pretty amazing, in my opinion. They're volunteers, and volunteers will help offer companionship. They can come into the house. They can offer respite for the family. so that the family can go out for a couple of hours, especially if they don't have us in there yet at the time. There's counseling and bereavement. And the counseling and bereavement services usually last for a year post-mortem for the family. So they will continue. There's groups that are available for the family members to come to if they feel that they need that. That's usually run by the chaplain services, but it is something that's available through hospice. And then there's us. There's the family that are caregivers. There's the CarePros that go in and also help the family with the clients. And we really provide mostly emotional care and personal care, but a lot of emotional support. We end up providing a lot of emotional support for the families sometimes. Sometimes they need it more than our clients do. Okay, so we want to build trust with our clients, and we want to do that by letting the clients take the lead. As we said earlier, our clients are going to react differently to different situations, and we want to follow their lead. They want to finish their journey, and we want to help facilitate them finishing their journey. We never want to judge their reactions. We don't really know what is the basis of that reaction, and we want to respect their wishes. And again, don't force our feelings. Don't insist on how they should act. And I can't say that enough. I mean, sometimes we're uncomfortable in a situation, and we think we have something that may make them feel better, but it may not. And so we want to let them tell us what they really need. We want to follow through on what they ask us to do, or what we say we're going to do. We don't want to forget that we've made that commitment to do something. Okay, it's really important. We always want to be honest. We don't want to say that we can do something that we can't do and then not do it, right? We don't want to allow silence. And again, silence is a hard thing for some people. Some people are really uncomfortable with it. Some people really require it. A lot of times, if your client doesn't want to talk, just sit there with them, hold their hand, whatever they need. But sometimes silence is the most therapeutic thing you can do, just having the presence of someone else in the room, being quiet with you, and sharing that experience. And we always want to respect their space. They may feel differently about how close they want you to get, and when they're talking to you. They may want a distance, they may not want a distance. They may want you to hold their hand, they may not want you to hold your hand. So we want to take their cues and follow through with what they want, but be able to respect their space. Again, we just want to take the lead from the client. Because this is not a situation where we're going to make them better, right? It's not a situation where we got to get them walking because we think they need to walk, or eating because we think they need to eat. This is a situation where we're really holding space. We're really holding space around them and keeping them comfortable so that they can pass comfortably and work through whatever they need to work through. Okay, when people are dying, they have similar desires. They want to be pain-free. They want to be alert and aware of what's happening to them. They want to have companionship. They want to have their family and friends around. They want to be accepted for who they've always been. They still want to maintain their individuality. They don't want to die alone. And it's hard sometimes. I know when I was working in Vinnie Hospice, and I had a client who was in Monroe Park at the time. And she was an older woman, and her son was in California. And I was doing my weekly checks on her every couple of days because she was transitioning and she was ready. And I walked into the room, and I realized that she was actively dying. I had the ability, because of being a hospice nurse and arranging my own schedule, to sit there with her for 2 hours while she passed. I held her hand, we didn't talk, watched her breathing, and I was able to be there so that she was not alone. And then I was able to call her son and say, Mom passed, I was with her the whole time. And that was a beautiful experience for me, and hopefully supportive for her son and her, because she wasn't alone. And it's horrible to be in a facility and to be by yourself and not have any family member there. They want to have familiar things around them. Maybe pictures of family, things that are important to them in their lives. They want to be cared for with love and respect and dignity. And they want their family to continue living after they're gone, right? And they want to know that that's going to happen and it's going to be okay. Okay, so the nearing death experience. There may be pain. There may be a loss of appetite. So we have to remember that there's a gradual decrease of appetite as the body is slowly shutting down. And we'll talk about this again later, but this can become a difficult situation because we show people we love them by feeding them, right? And you got a family member that's going to come in and say, oh, Mom, eat some more. Come on, Mom, you got to eat. You got to get stronger. And their body is shutting down. They are not hungry. You know, everything is closing in. Everything is shutting down. They're conserving energy for the whole process of dying. And so, you know, in all of my hospice experience, more often than not, I have family members that are trying to feed people because that's how they show their love. And it's hard. It's hard to deal with the family sometimes.
But even not being in hospice, my mother-in-law is 81, my mom is 75, and their appetite has totally changed. My mom doesn't eat as much, my mother-in-law doesn't eat as much either. As you get older, you tend to eat less. Most people.
It's true. I mean, but think about it. We eat more when we're hungry, when we're exercising, when we're young, when we're moving. And then as we stop all of that, our body doesn't need the calories.
My last little client I had, and her husband was passing, she thought we were starving him to death.
Exactly.
We tried to explain to her that he couldn't swallow at the time, but she wanted to talk to the doctor, and so she figured we were starving him to death.
Exactly. And I think too, the spouses, I mean, we all have, you know, the clients have their work to do, but the family members have their work to do. And you know, we don't know what kind of guilt, what kind of issues, what kind of concerns they're working through, you know, and that's why a lot of our support is for the family members as well as the clients, because oftentimes if we allow the space and the support for the clients, they're going to go through this process regardless, and it's the family members that are going to be more conflicted. And the feeding is a big thing. It's a huge thing.
She constantly wanted to feed him, you know. He can't eat ice cream. I go, no, honey, he can't swallow it all.
Right.
But I could hardly get that through to her. She wanted to talk to the doctor because she figured, well, I guess so if you're starving him to death. You know?
Right, you're going to kill him if you're starving him to death, right? Right. I mean, so it becomes a little idiotic, but it's how they're responding to it. There might be nausea and vomiting, and that might be because of the medications. It could be from anxiety, it could be from anything, but that's something else that you might see. Changes in breathing. You're going to see maybe some shortness of breath. You're going to see some other changes that we'll talk about when it's closer to the end. There might be increased body odor. There might be skin concerns. Again, we really want to prevent our hospice clients from breaking down. Bed sores are very, very painful, and especially when they're toward the end and they're terminal and they're not getting the protein and the things that they need, and we'll talk about that a little bit more too. And there might be weakness. So all of these physical changes start to take place, and it's the whole function of the body shutting down. And we're seeing these changes because the body's shutting down, and it might be rapid or it might be gradual. Each client, again, is going to be individual, and so we don't know yet what that's going to be until we're there with them. There are physical changes nearing death. In addition, their consciousness changes. So they might have hallucinations. There might be confusion. There's something called terminal restlessness, severe agitation towards the end. I know my mom went through that too. That's why they give them Ativan often, or if they're allergic to Ativan, they'll give them something else. They might just be going in, they might have personality changes, or they might just be slowly slipping away into an unconscious state, and they're hard to arouse. Okay. There might be loss of bladder control. One of the big problems that we find is constipation. And I know as a hospice nurse, I used to go and give fleets enemas all the time to our clients. Even though our clients are on bed rest, they're not able to get up, they're not eating a lot, they're also not drinking a lot, so they're getting very dehydrated. And our bowels are still working, right? And so there's no movement, there's dehydration, and they get constipated very easily. And it's uncomfortable. It's really uncomfortable for them. Like, they used to hate me coming in and giving them the enemas, but they were better, they felt better afterwards. And again, there's going to be a slow decrease in urinary output. And also remember, there's less intake, so there's less fluid intake too. Their vital signs are going to fluctuate as the body shuts down. And they could start to perspire a lot, so they may feel cold and clammy because it's just a process of the body shutting down. So nearing death awareness. When people are dying, they're trying to tell you what they're experiencing oftentimes, and there's a lot of things that happen. They might be gesturing or smiling. They may be talking to their ancestors, a lot of them vision. And I didn't really believe in that until I worked in hospice. And it's, you can feel it. I mean, you can feel it in the room and you can sense it. They talk in metaphors. You know, they say, I'm going home now, or I've got to go catch that train. And you know they're telling you they're ready to leave. So we want to try and intuit what they're really telling us, because they're talking to us. They're telling us what's going on. They're telling us the process that they're experiencing. And it happens consistently. It really does happen consistently. Okay, days and hours before death. So the one thing I do want to say before we go into all of this is that when a client dies on hospice, it is not a 911 call, okay? Sometimes family members freak out. They call 911. If the team gets there, you want to make sure they see the DNR cell. They don't start CPR because it's mandatory for them legally to start CPR unless they see a DNR. And you want to give them the number of the hospice company so that they can call and confirm that this client is on hospice. They're not going to take them to hospital, okay? Because if a client is not on hospice and they die at home, they have to be taken to the hospital. They go to the mortuary in the hospital to be pronounced, and they usually will have an autopsy to find out what the cause of death was. If someone is on hospice, they're allowed to die at home. They don't need to be taken to the hospital. And once the hospice nurse gets there, she can declare time of death and call the doctor, and that's what will be on their death certificate. So it's a very different situation when someone's on hospice. So it's important, if the family freaks and they call EMS, that you guys know where that DNR is and can give them the number of hospice so that they don't have to do anything with the client. But as far as death goes, remember, each person's death is going to be unique. So their eyes, they might become glassy, they might become teary-eyed, they might be half open. At time of death, their pupils will dilate. It's just a physiological reaction that happens. Modeling. So modeling is because there's a decreased circulation of blood to the body. And so it appears to be like a bruising, like a purple or a red bruise. You usually see it on the sole of the feet first, but you can also see it on the fingertips, okay? And that's a good sign that someone is really nearing death when you start to see the modeling. Breathing problems, chain stroke respirations. Fast 1 minute, slow the next minute. Fast 1 minute, slow the next minute. Just a different type of labored breathing. The death rattle that we hear, all it is the mucus and secretions that are in the throat that the client isn't clearing. So as that breath is going through that liquid, it's making that rattle sound. And that's what the death rattle is. And then apnea. And so with the woman I was talking about, as we start to shut down, we have periods of apnea, which is a period where we stop breathing, okay? And when I was sitting with her, I was watching her periods of apnea, and I was watching them extend. So she might go for 5 seconds, and then it might be another 5 seconds for a while, and then it was 10 seconds. And then sometimes it seems so long, like you're sure they're gone, and then they'll take a breath. But the apnea is just the slowing down of the breathing, and it's the periods between breaths. And they lengthen as someone who is dying peacefully, they'll lengthen, okay? Their pulse, it might become really weak, it might become really, really hard to find. And then sometimes there's a surge of energy. And this also confuses the families, right? Because all of a sudden they're not eating, they're sleeping, and all of a sudden, oh my God, I want a hamburger right now. And they might eat it, right? And the family thinks, oh, they're doing better. And then within 24 hours, they're gone. So sometimes you see that kind of surge of energy, and it can be very, very confusing.
Man had a case for grilled cheese sandwich. I made him a sandwich. He took one bite and he was satisfied with that.
Mm-hmm. My mom, who was passing in the hospital, she had us hysterical because she was just out of it for so long periods, and all of a sudden she woke up and said, "Am I dead yet?" I said, "No, Mom." "No, Mom. Go back to sleep." You know, my kids were there, and we just laughed because it was typical of my mom.
My father was in the hospital. He had heart failure and lung failure, and he ate a full course meal.
Yeah.
And then he died.
He died. Yeah. And it happens more than you think. You know, it's that last surge of energy that the body has, and then they let go. And the other thing is really important that I want to remind you guys, of all of our senses, our hearing is the last one to go. So you're sitting there, your client is lying there in bed. You okay, honey? I know, it's hard. It's hard for me to talk for this one too. Your client is lying there, you think they're unconscious, you know, you think that they don't know what's going on. They're going to hear every single word that you say. Another example, and then I'm going to cry too. With my mom in hospital. So my daughter and my, at that point, not son-in-law, he finally, when my mom was in hospital on hospice, he said, "Okay, I've got to propose officially." I mean, they've been going together since high school, right? And they were in their late 20s. And so he came and proposed to her, my daughter, while they were in the hospital. And my daughter didn't know this, we all knew it. And they came back to the room, and we were talking about it. And my mom's words were, "Happy, happy, happy." Because she heard us, and she knew that it had happened. So it's really important to understand that they hear you when you're around them. Okay. So pain awareness. Again, pain is individual. Everyone reacts to pain differently, right? We want to listen to our clients. We want to take them seriously. If they are telling you that their pain is increasing, or it's changing, or it's shifting, you want to call the hospice nurse. You want to say, "Look, this is what I'm seeing, this is what I'm hearing. You need to come out and reevaluate the client," because they can adjust the medications. Remember, it is comfort care. No one should die in pain for any reason, if we can help it. We want to keep them as comfortable as possible, and we also want to remember that we are not allowed to administer the morphine, okay? So the Ativan, usually the comfort care kit that the hospice leaves is Ativan and morphine. The Ativan is for that terminal restlessness that we talked about, where they get really, really agitated sometimes at the end of life. And the morphine is for pain or for breathing issues. It's a small, small dose, but it's enough to affect their body to calm them down, whatever their symptoms are, but we're not allowed to give it. So the family should be giving it, or the client can take it themselves. We have a client on hospice, and she's still capable of saying, "Go get me my morphine." The caregiver will go get it from the fridge, bring it to her, and she'll shoot it into her mouth. It's just absorbed into the mucous membrane of the mouth. And again, it's in a little TB syringe. It's a tiny, tiny dose. But you need to be comfortable with these drugs if you want to work with someone who's on hospice. Okay, so our role as caregivers, we support the clients and we support their families. Personal care is a big one, right? We want to be sensitive to what the client's feeling. We want to offer reassurance. We always want to explain what we're doing and involve the client in the decisions. They may not want their bath right now. You know, they may not want to do something. We want to let them take the lead, as we said earlier. Mouth care becomes really important, especially towards the end. You want to do mouth care every 2 hours, like you want to do personal care every 2 hours, keep them clean. Sometimes we need to swab our clients' mouths because they're not able to do it for themselves. Sometimes they're mouth breathing, so it becomes a problem. Don't forget, there's dehydration. There might be a fungal infection in their mouth. A lot of them end up with thrush, so they have a little nystatin, swish, and swallow, which they may not be able to do, but we want to swab it in for them. They may have open sores. They may have cracked lips. Their dentures start to fit poorly because they've lost weight. You know, the structure of their mouth is changing. Their teeth may be decaying and we don't realize it. All of this may be part of the dying process. So mouth care is really, really important, as is skin care. We want to reposition them every 2 hours because we want to prevent breakdown. Bed sores, as I said earlier, are painful. What happens is that there's a lack of blood supply to the tissue, so there's a lack of oxygen to the tissue, and so the tissue starts to break down, in addition to having a lack of protein that they need to help maintain their tissue. And so a bed sore can happen in 90 minutes, but if you have a client and you're turning them every 2 hours, and you see a red mark, and that red mark is not gone in 30 minutes after you've repositioned them, that's the beginning of a bed sore. So you really want to make sure that that area you're really careful with if you reposition them back to another position, because that blanching redness should resolve itself. I mean, when we like lay on our hand or something and it blanches, that's resolved in 10 minutes the most, right? So if it's still there in 30 minutes, that's the beginning of skin breakdown. Mealtime, so we've already touched on this, right? We don't want to force them to eat. They know, their body knows what they need. So if they want something, they're going to ask for it. But remember, the body needs the energy to die, which sounds kind of silly. It's counterintuitive, but the body needs the energy to shut down. And so it's shifting where it's focusing. And we just need to go with that. And again, we need to support our clients' families because they're the ones that are going to have more problems with them not eating than the client is. But if they are eating, we want to plan small, frequent meals for them. We want to keep the portions small. Beverages between meals as opposed to during meals, because if you drink, it fills you up, right? And so they have a limited capacity of what you're going to get in them anyway. So don't give them a lot while they're eating, but also frequently offer them like frozen juice or popsicles or something that can get some fluid in them. They may have to drink with a straw. You may have to take a syringe without a needle and put some fluid in their mouth for them because they can't do it, or even feed them fluid with a teaspoon because they can't do it on their own. And again, we want to avoid citrus juices because if they have sores in their mouth, it's going to burn. Yeah, it's really going to hurt. So we want to do that. And then we talked about difficulty swallowing. The hospice people will bring out a thickened liquid, like a powder that you can add to liquids. And so there's 3 consistencies. There's nectar, honey, and pudding. And so they may ask you to add some powder to their juice or whatever because they can't swallow liquids. They're going to aspirate and it's going to be really uncomfortable. So the thickened liquids might be something that you're serving them. Want to give them time to eat, make it comfortable for them, make sure they're sitting up, okay? As we get older anyway, choking is a problem for a lot of our clients, and aspiration pneumonias are a big deal. So we want to make sure they're sitting up. And it also helps to promote digestion because even with the aging process, our digestive process changes too, so it's hard. And we want to encourage them to feed themselves and do as much as they can. But again, if they can't, if they're at a point where they can't, then we're going to help them. If they're having problems with constipation, we want to think about giving them maybe prunes or prune juice if we can, if they like it. Some people don't like it. Raw fruits if they can eat it, maybe some grains, if they like whole wheat bread or something, if they just want a slice of toast or something like that. Also, the bread or the crackers are going to help with nausea, right? So we might want to offer them that. Protein supplements, remember, the skin is breaking down because it's not getting the oxygen or the protein the body needs. So protein supplements may be useful. I mean, Ensure is pretty gross, but they have a ton of different supplements out there now because it's all the rage, right? You exercise, you drink your protein drink. So there's lots of options out there now for them. Remember, our verbal communication is less than 25% of how we communicate. Our nonverbal communication is everything. It's our posture, it's our facial expressions, it's the way we hold ourselves, and it's so important that we remember that our clients, even if they're not on hospice, especially if they have dementia, are reading our nonverbal communication, and we want to be aware of that. We also want to read theirs, though. We want to be aware of their nonverbal communication. You may have a stellar client who doesn't want to complain that they're in pain because that's their personality. but you see them wincing, you see them fidgeting, you see that they need some kind of repositioning. Effective listening. It's another one. We don't always do that so well, do we? It's important to listen to your client and restate what you think you understand they're saying, right? But challenge us to listen, okay? We get distracted because we're doing something else. We're thinking about what we need to do next, or we're anticipating what we think the person we're talking to is saying. So you're having a conversation, not even just with your clients, with your husband, your friends, and you say something and you say, oh, I know what they're gonna say to me, and then you respond to that. You haven't even given them a chance to say what they're really gonna say. We do it all the time. It's how and who we are. And for a lot of us, sometimes you're there with the client, you want to support them, but you have a ton of tasks that you need to do. So you might be thinking about, okay, I'm going to run out of time. I need to get all this done, or else whoever's following me is going to give me a load of grief because I didn't get it done, right? But we can make sure that the client sees and hears us when we're talking to them, and we can make sure that we see and hear them. So you've got eye contact, right? And you know that you're focusing on each other. We want to be patient. Allow the client the time they need to talk. Allow them to do what they need to do. We want to be cautious about putting words into their mouths. We don't want to overwhelm a client who is quiet or passive, because some people don't like to talk, and we don't want to be a chatty Cathy if that's what they don't want, right? And we want to be present. We want to be patient, and we want to be present, and we want to let our clients know that we're present for them. Okay. Responding to questions about death. This is a big one too, because some of us aren't comfortable with it. And we want to make sure that we know how to respond to them, and we never want to say to them, I understand, because we don't, right? We're not there. We don't understand. But we want to focus on what's still possible, not what they've lost. Try to reframe it maybe for them. We want to consider their coping style and their approach, and tailor our approach towards their coping style. We want to know that some questions don't have answers. We can't answer everything. Why me? How do you answer that, right? So you say, I don't know, right? And we want to acknowledge their struggle instead of avoiding it. So again, if you're working with a hospice client, you have to be comfortable with death. You have to be comfortable with not having all the answers. If they ask you if they're dying, maybe you can respond by saying, do you feel like you're ready? To give them something to think about. If they say, why me? You don't know. I don't know, maybe. Or if they say that they're not ready to die yet, maybe you can say, well, how can I help you prepare? What can I do for you? That might be a way to respond. Or if they're crying, let them cry. And just ask them, can I just be here with you quietly and sit here? We don't have to talk unless you want to. But you tell me what you want and what you need. And those are ways to respond supportively to them. Okay. Kubler-Ross's stages of death and stages of grief. So again, grief is individual for all of us, right? And a lot of it's based on the client's individual life experiences and how they handle challenges and how they handle things. And their grief, it might change from day to day. It might change from moment to moment. So we want to remember that it's individual for the client. Denial is a defense mechanism. It's a way for the mind to take in the information slowly. I'm not going to die. But they're really processing what they've been told, okay? Anger is a defense mechanism. We get angry and we lash out. But it's a way for us, again, it's healthy. Anger is healthy. It helps us to move on. Once we've lashed out, we've expressed our anger, then we can move on. And then the next stage is bargaining. There's some hope that maybe if there's something they can do, the situation will change. The diagnosis will go away. And that's bargaining. We all do that we do it for other reasons in our lives too. If you just let me do this, Now, I promise you I won't do this later, right? I mean, it's part of what we do. Depression is natural. It's natural to feel sad. It's natural to have regrets. It's natural to have uncertainty. We're going through a hard thing right now, and it's natural to be depressed until you can start to accept the fact that you're dying. And towards the end of depression, you're starting to accept that. And then acceptance is just when someone comes to terms with their death. And some people may go through all these stages. Some people may not go through any of them. Some people may start with depression, go back to denial, anger. They might fluctuate all around. But those are the basic stages of grief that people cycle through as they're dying. So it's important for us to understand the stages, because then we can understand our clients' reactions to them, right? And we can understand how they're behaving, maybe what stage they're in, so we can find a way to support them within that stage. It helps us to have more empathy for the client, to understand that these are stages that people go through. And it helps us to better help them to achieve peace and to achieve acceptance in the end. Anticipatory grief is another thing that people experience when they get bad news. It occurs before the death or any loss. It provides an opportunity possibly for personal growth, to find a way for meaning and closure. It's an opportunity to reconcile differences, to say your sorries, your apologies to people that you need to say it to say goodbye to the people that you need to say it to. So anticipatory grief, again, this is all healthy, and it's all part of the process of letting go as we pass. Okay, family members. You know, I mean, sometimes I think it's harder to deal with the families than it is to deal with our clients, right? Oftentimes it is harder to deal with the families. So you've got a family member who's dealing with their own challenges. Sometimes they're going to pull together. Sometimes there's going to be unresolved conflicts that come to the surface, and we don't know their history. You know, even just with our regular clients, you've got a kid that's neglectful. Why is that child neglectful? We don't know what kind of a parent that client was. We don't know what their relationship was growing up. So we have to be aware that there's stuff that we just don't know. And we can't impose what we think the family should be doing on them, because we don't really know their history. But we're going to come in contact with a lot of family members. You're going to have kids that haven't been around that maybe you've never met. You're going to have nieces and nephews, maybe grandchildren that come. And we're going to remember that they have a history also of how they interact with each other, right? So coping is affected by a pattern that's established long ago, okay, in their history. It's also affected by the dying person's role in the family, whether it's a grandparent or whether it's a child, okay? It's affected by the length of the illness, whether they've had a long, drawn-out period of cancer, or whether it was an automobile accident and it was quick, okay? It could be affected by how much social support the family has, and that could affect all of their coping. And also the cultural differences. So that sheet that we handed out, some cultures express themselves differently. In some cultures, they may not be willing to accept outside help, right? They want to just take care of the family by themselves, but maybe they can't and they need the help. So cultural differences is going to affect their coping. So we always want to stay professional. We always want to stay focused. We want to be good listeners for the family members too, just not for our clients. We want to remember that they're going to express a range of emotions, and that we need to be comfortable with that. And we want to listen with empathy for them. We want to make eye contact with them. Sometimes gentle touch, and again, you need to know your client or the people, but sometimes just holding someone's hand, rubbing their back for a moment, just telling them having that gentle touch and that eye contact is a way to say to them, I understand. I'm here and I understand. And I'm here for you as well as your client. Always want to be respectful. If we treat someone with respect, we're treating them with compassion, and that's important. And we want to encourage our family members to take risks, but to take time for themselves. I'm here. Why don't you go get a cup of coffee? Go walk in the park. Just go take a half an hour if you need to. Go do something for yourself. I'm here. I have your phone number. I'll call you if you need to come back. Let them know that they can leave and that that you're allowing them that space. And then finally, you guys. You want to accept your feelings, right? Don't judge yourselves. Your feelings are your feelings. Your reactions are your reactions, right? You want to know that it's normal to feel a whole different emotional phase for yourselves too. There's a whole spectrum of emotions that you may go through, especially if you've worked with the client for a long time and you've become attached to that client too. It could be painful. You want to know how you cope, right? And know that your coping patterns are also going to affect your life and how you're going to feel. So you want to know what your coping patterns are. And you just want to take care of yourselves. So maybe you need to join a support group, or maybe you want to talk to a friend, right? Sometimes just making a list of what you're grateful for every day helps you reframe your day and how you're approaching it. Be yourself, let your feelings out. If you need to cry, cry. Crying is our body's natural way to release pain. So we cry to release that pain, and it's very therapeutic. And then exercise, meditation, yoga, you've heard all of that before, but sometimes just taking a walk in the park, being with nature is another way to cope. You know your coping mechanisms, and you just want to make sure that you are taking advantage of those. And talk to someone, talk to the client care manager, whoever you need to talk to. Okay. Any questions? It's a hard topic. It's a lot of information. There's a lot going on. And again, I mean, I think that hospice is amazing, and I loved working with hospice. Know yourself, though. Know whether it's something you can or can't do.